Good morning and welcome to The Future Truly Is Now. We are here to show you, not necessarily to blow your mind, but to show you how ideas and people are changing our lives. We've talked about the power of ideas here at this conference, and the ideas all come from human capital, from talented people. And today we have three extremely talented people who will tell us what they're doing, the companies that they have started, and how they will positively change our lives. On my far right, I have William Santana Lee. Mr. Lee is an innovator and entrepreneur with over 25 years of experience and expertise gained both in the auto industry and several startups. He was born in New York City. He attended college at Carnegie Mellon, where he got a Bachelor of Science in Electrical Engineering. He worked for Ford Motor for 10 years. I believe he had 12 different jobs and worked on 4 different continents during that period of time. He also got an MBA while he was at Ford from Detroit Mercy, and he had a belief that's developed while he was at Ford, and also especially after 9/11, being a native of New York City, that he believed that machines could be taught to operate on their own, and he felt very strongly that technology, with all of its advances, had not advanced in the area of law enforcement and protectors of those that are our first responders and we rely on for security. On my right here is Nina Tandon. Nina also grew up in New York City and started out on a similar path as Mr. Lee, as she was very interested in electrical engineering, and she got her master's in electrical engineering from Cooper Union, where she is also taught. She was very interested in developing video games and building robots like you will see Mr. Lee is involved with today. She earned her master's at MIT and her doctorate in bioengineering, biomedical engineering. She made this transition when she met her mentor, Jordana, and then had an opportunity to work in Italy on a Fulbright scholarship. She decided she might want to form a company someday, so she got her MBA also at Columbia, where she followed Jordana. And she has been working in the area of tissue replacement and creating tissue in the lab, and today is working on bone, as we'll hear about in a minute. And on my left is Dr. Frederick Mall, who grew up in Seattle, Washington, and attended that phenomenal institution of higher learning, University of California at Berkeley. Go Bears. After graduation with a degree in economics, he decided that he wanted to go to medical school. Both his parents were physicians. He got his degree at the University of Washington and became a resident in surgery. At that time, minimally invasive surgery was just starting, and he found this area of tremendous interest and actually started a company to develop tools of this area. He sold that company, got the bug of basically being an entrepreneur while advancing the science, and got an MBA from Stanford. So you see we all have MBAs, at least our 3 panelists all have MBAs up here. While he was at Stanford, he was introduced to robotics and became very interested in what robotic surgery could do. He has been involved with a number of companies which he started that are involved in robotic surgeries, and he'll be telling us about his most recent endeavor here in a few minutes. So we will go back to our Robocop expert, Mr. Lee. Tell us, what are you doing today, and why, and what can we expect from it?
Sure. Well, honored to be here. Really appreciate the opportunity to tell you a bit about Nightscope. We're developing technology to predict and prevent crime. If we can go to the first slide. Thank you. So these autonomous data machines are intended to predict and prevent crime. Crime has a $1 trillion negative economic impact on the economy annually here in the US. That is a hidden tax we all pay every single year, besides the psychological and emotional toll. Violent crime occurs every 26 seconds, a property crime every 3.5 seconds. Globally, our collective societies spend over $500 billion a year on security. And what is the most profound question we could ask? What is the big idea? How could you make something so powerful really change society? What if we could develop a set of technologies that could cut crime by 50%? Period, full stop. What would happen? What would be the impact on housing values in a community? What would be the impact on insurance rates? And as well as the stability of financial markets and the quality of life, as well as the viability of your business, the safety of your family. What if we could make the United States of America the safest country in the world? Talk to me about the impact on infrastructure, on education, on trade, on everything. This would literally be the game changer. So, first line of defense for law enforcement is to have a physical presence. Physically being there changes criminal behavior. 90% of criminals aren't all that bright. They're looking for the path of least resistance. So I could put a marked law enforcement vehicle in front of your home or your office, and criminal behavior will change. So you can start by having a 5-foot-tall, 3-foot-wide, 300-pound machine that roams around autonomously. And that means not remote control. So literally roams around on its own, similar to a lot of the self-driving technologies that will hit the auto industry in the coming decade or two. And also have this machine be able to recharge autonomously, 24/7 without human intervention. That makes things a lot more interesting. And what if that machine could see, feel, hear, and smell? Nighttime, daytime, 360-degree video, optical character recognition, thermal imaging, audio event detection, gesture recognition, and for high-value targets, WMD, threat detection capability for biochemical, radiation, and pathogens. And what if you had a user interface that you could provide clients, as well as potentially the public, access to the data from those machines? So now I'm going to go do something you're not supposed to do, which is a live demo. So I'm going to go up here and cross my fingers. The folks back there are going to switch it over. There we go. So this is what we call the Nightscope Security Operations Center. This is a browser-based user interface that our clients are able to utilize. Obviously, in security, starting at the upper left, you're looking at different events that occurred throughout the day, so the guards can then clear those events and also play the particular video, go back in time and search on those things. This is a live stream from Machine 2 at Nightscope headquarters in Silicon Valley. This is live right now. We can check on the machine's health. We can emergency stop it here. We can check on battery levels, cell temperatures, etc. And then we also have a optical character recognition system on the machine that runs 300 license plates a minute. And we run that against a database that we get from the government every 4 hours of every plate that's stolen, every stolen car or felon tied to that plate. And we can then obviously alert the authorities or the personnel that's there. A few other interesting things that we're working on later this year is you'll be able to hit this broadcast button and be able to speak through a machine or a number of machines. So if, let's say you have a live shooter situation, or if you're at a school campus on the other side on the intercom, have a two-way communication, or let's say you have a young freshman uncomfortable walking from the library to the dorm at 3 o'clock in the morning, she should be able to get a physical escort. And then also be able to drag and drop these icons here. So let's say a guard can't see what machine 72 is seeing, a mile away. He or she should be able to not only log in here, but on a mobile device and see what those machines are actually doing. And obviously, as we learn more and more about the environment, we can send more and more thoughtful alerts. And the idea here is for the machines to do the computational heavy, monotonous, and sometimes dangerous work, and let the humans do the strategic kind of decision-making work. All right, thank you. So if we go back to the slides. So what if you could crowdsource security? And think about what happened after the Boston Marathon bombing. Everyone was trying to help, putting stuff on YouTube, putting stuff on Twitter, uploading stuff on CNN. But if you're the crime analyst, good luck trying to analyze that all in real time. But what if you could actually do that and then ingest all the data that comes out of these machines, which is 90 terabytes of data per machine per annum, and be able to analyze all that real-time on-site data and then 100 plus historical pieces of information of any primary, secondary, or tertiary impact of crime in that particular area. Crunch all that, and let's say we're going to push a yellow, orange, or red alert. What if we were to turn on all the sensors for everyone in that community to see everything? Right? Gets away from the privacy issue, but also deters crime. Like if you're the guy who wants to go steal the red car down the street, and you see a few hundred machines running around, and the community's all bought in, and you know if you go try to steal that car, we're going to turn on everything for everyone to see everything, you're going to get caught. And the likelihood you're going to go do something silly is probably all about nil. And that's why we're pretty confident we're on a very good path as we deploy these this year. We've already started deployments to get to our end goal, to be able to cut crime by 50% in a geofenced area. So we offer these on a machine-as-a-service business model. So an off-duty law enforcement officer, depending on the part of the country, is somewhere between $75 to $90 an hour. A guard is roughly $25 an hour. We offer these machines at $6.25 per hour. And the idea here is not to have a one-for-one human-machine replacement. The most powerful combination here is to give the law enforcement officers and security guards really smart eyes and ears to do their jobs that much more effectively, and then also be a huge force multiplier at a very cost-effective means. So the media has had some more than interest in what we're doing, and that's then flooded the number of clients we have on a huge wait list. We're probably over, we just started, and we've got maybe 100 huge clients on a wait list worth a few $100 million a year. And you'll start seeing these in malls, corporate campuses, college campuses, stadiums. A lot of sporting teams are interested in this, and then all the obvious high-value target type of locations. So appreciate it. Please visit us at knightscope.com or reach out to me directly. Happy to have you understand a little bit more about what we're doing, and we always appreciate feedback. So thank you very much indeed.
Thank you. So, Bill, by the end of this year, how many of these robots will Knightscope have out in the field?
We're focused on Silicon Valley for this next 12 to 18 months. The highest risk in the business is human-machine interface. Right? This is what we're doing is not normal. It was supposed to happen in 2050, not 2015. So we need to make sure that that interaction goes as smoothly as possible. We've got interest to put tens of thousands up to 100,000 out just in the US, and then we've got maybe 2-3 dozen countries interested.
Great, thank you. So Nina, you started out life wanting to work on one of these machines probably, and maybe this got your interest back up, but you know, you've had a very interesting journey with respect to the human body, to cell reproduction. So what is taking you to bone, and what is Epibone doing today, and what excites you about it?
Right. So I grew up in New York City, actually. A couple of my friends from nursery school are here in the audience. Hi, ladies. Let's see. I grew up in a big family where there was a lot of, you know, my two sisters are colorblind and my brother is nightblind, and so I was tuned to this idea very early that biology is a technology that could either go right or wrong. And I followed that through electrical engineering and then landed in tissue engineering about a few years later because of falling in love with the heart, actually. The heart being our body's largest bioelectrical source, signals 1,000 times stronger than the brain. And my office mate, who's my co-founder, was studying bone, which is actually much more ready to be able to help people. So that's actually how we got started. I have a couple of slides that can explain what we're doing. So if we could just skip to the next one, or do I actually have a clicker? Awesome. So next slide, please. So one thing that people probably don't often think about unless they're in this field is that after blood transfusions, bones are actually the most implanted material in the body. You know, over 2 million procedures worldwide costing several billions of dollars. And, you know, not to be macabre, but, you know, quite simply the only way to get human bone is to cut it out of a human. And we hope to change that by collaborating with the cells that build our bones every day and use those cells, harness their power to grow new bones using those cells in the lab. Because if you think about, you know, there's just not enough bone to go around, especially with pediatric patients. You know, a lot of people ask me about the aging population, and I think that it's really important to note that, yes, people are living longer and longer, and if we're lucky and we live to 115, we need our implants to keep up with us, especially if we consider that over the past decade alone, the rate of ACL tears in the pediatric population has gone up 400%, right? We're getting injured. It's not just an aging population, but the lifetime. If we're getting injured at 15 and living till 115, it's just not acceptable anymore to consider that our hip replacements are only lasting 15 years, right? We need them to live with us. And this is only going to become more and more the case as the world globalizes. So what do? We take stem cells, and we take two things from the patient, right? We take an image, a CT scan, so three-dimensional X-ray, kind of, and we extract the three-dimensional data from that in order to generate an anatomically precise bone scaffolding. Actually, I have a little sample here. Right, looks like this, right? Oh, could we go back to the last slide, please? Thank you. And so we take that three-dimensional data and we engineer an anatomically precise bone scaffold, right? At the same time, we also machine the opposite of that, three-dimensionally. So we 3D print and 3D micromill all of the pieces using this 3D data. We also take a small fat sample from patients so that we can extract the mesenchymal stem cells out of those. And we infuse, using this bioreactor system, those cells into the bone scaffolding, right? So that's the second step here. And then we mature the bone over the course of about 3 weeks, and then the bone is ready for implantation. So this next slide shows a video that kind of sums that all up in about 10 seconds. Right, so we machine the scaffold, grow up the cells, do lots of machining and 3D printing and cultivating of the cells, and then and there we go, voila. I hope I've hinted at some of the benefits of having living medical devices. That are in an anatomically precise shape. There's a perfect fit, not just in shape, but also immunologically, because it's made out of your own cells. And so hopefully it will better integrate and avoid the complications of foreign body implantation. And because it's alive, we're hoping that it will continue to remodel and grow along with the patient. Okay, we're undergoing preclinical validation at this very moment. My colleagues are in Louisiana implanting pigs. We've implanted 20 pigs to date, and we have seen over the course of implantation, the graft, if you can see on the left here, integrates more and more over time, such that even after 6 months, it's almost indistinguishable, the epibone graft from the native bone tissue. And another beautiful thing that surgeons constantly ask us about is vascularization. They're used to doing surgeries that are called free flap surgeries that involve microvascular connections, and actually what's interesting about our graft is that it vascularizes post-implantation. So we actually avoid that discussion entirely. That's where we are with the science. And in terms of funding, we've closed on a friends and family round to the tune of $4.5 million, which includes the New York City Investment Fund, which we're really excited about. We're based in Harlem. I'd love to talk about the life sciences ecosystem if that's something anyone's interested in, especially as a Roosevelt Islander in New York City. And that's kind of, that's where we are right now.
Oh.
Thank you.
Thank you, Michelle. So, Nina, how far are we on a best case scenario from your actually doing your first implant into a human?
Right. So the jury, we're actually, this is a strategic discussion amongst ourselves. In addition, you can imagine the regulatory impacts of implanting sooner rather than later. We're about, the clinical trials for this kind of device would likely take about 8 years. So backing up from there, when do we start? Right now we're trying to decide whether it makes sense to do what's called a compassionate implantation that would be under an institutional review board type of mechanism, or to go straight into just to continue doing our preclinical work and then apply for this would be the longer play for a clinical trial, which we're about 2-3 years away from being able to do. So depending on what we decide, and this is actually a strategic question because we don't want to shoot ourselves in the foot should we move too early. We're anywhere between 12 and 24 months from our first implantation.
Okay.
Yeah.
Well, thank you. So, Dr. Moll, while Nina is developing tissue and bone in the lab, you're finding out a way to basically improve how we are operated on. So, tell us what's going on today at ORIS.
Thank you. So let me start out with a mind-blowing statistic. 10,000 people in this country every day are turning 65. That may not be too alarming, but if you think about the health of the healthcare system, it is creating an enormous, a tidal wave of need with regard to medical and surgical intervention. So it's both a problem, but we think an even bigger opportunity. And so at Auris, we're answering the question, how do we perform medical intervention for the next 20, the next 50 years, rather than let it sit where it is today, because it's inefficient and it has great room for improvement. So to understand sort of the progression of technology and technique in surgery, it's fun to go back to almost 100 years ago, where surgery was brand new and ushered in by the use of general anesthesia. And for about 80 years, surgery was really more about perfecting technique than really embracing technology. You needed very good hands, and you needed a good brain, and you could do a good technique or a good job of surgery. I was lucky enough to be trained in the 1980s when the idea of minimally invasive surgery was just showing up. And the fundamental impact that minimally invasive surgery had on the surgeon was that all of a sudden his hands weren't that useful anymore because they were too big to go through a puncture wound in the abdominal wall or the chest wall. And so things began to reshuffle and technology came into focus. So I spent a long time in laparoscopic innovation, and then was lucky enough to be introduced to a very interesting project at the Stanford Research Institute called telesurgery, which was aimed at battlefield applications. The idea being that a doctor would sit in the MASH unit and teleport surgical technique to the battlefield in order to deliver much faster intervention and keep him safe and away from the hostilities. Well, as I usually describe it, it was probably a terrible misuse of the taxpayers' money, but it did really drive home for me the idea of how to solve the basic dilemma in minimally invasive surgery, and it's this. You see this gentleman who is a very good surgeon using long tools on the outside, but what's going on in the inside? He's struggling mightily to tie a knot. Now, tying a knot's pretty simple outside the body. It's extraordinarily difficult inside the body if you're working with chopsticks. And so this is not good surgery, and minimally invasive technique was an enormous challenge, and the void had to be filled by a technology that helped with dexterity without your hands physically being able to do what they used to do when one made a big incision. And this is the idea of telesurgery, and it's something that we developed at Intuitive Surgical, and it's really a translation, an electronic translation of hand movements from outside the body to inside the body to do dexterous technique in the abdominal and chest cavity. So that was the Da Vinci system. It's been extraordinarily successful. The company enjoys a very high market cap. But the targets and techniques of what we're going to need 10 years from now and 20 years from now are not really well aligned with current day robotics. And I'm extraordinarily excited about the next generation of medical intervention, where the game has really changed quite a bit. This unstoppable trend of medical minimally invasive surgery from a big incision to a smaller incision or a few small incisions to no incision is really, as I say, unstoppable and logical when we understand more about disease itself and really focus on the cells that are causing disease rather than the organs that are causing disease. In other words, disease is based on cellular malfunction. It is not usually, which leads sometimes to organ failure, but the best way to treat disease is to focus on a specific cell group that are bad actors. And if one can find those cells early enough, it can be a much less invasive approach to treating disease. So we're combining early diagnosis that's afforded to us by modern imaging with the technical advancements in both robotics, miniaturization, and increased capability together with sensing, and by that I mean both tiny cameras but also tiny sensors to delineate different types of tissue, and wrap that into a paradigm that says the world needs advancement in medical intervention for both complex and routine procedures, but it has to be done at a cost that works with the new realities of healthcare. And so Auris has built, and we continue to refine it, but we're using it clinically today, a digital robotic platform for what we believe are the next generation of medical interventions. So I liken this, the next generation of surgery to drone strikes, which, as you know, has been in the news recently. What are the similarities? They're both going after terrorist cells. Now, cancer has been described as a terrorist inside the body, and I think it's a great analogy. So you think about a drone where, as you saw in the early video that Richard showed, when you do Da Vinci surgery, you're not physically present at the patient's side. You're remote, and you're guiding, much like you'd guide a drone, to search and destroy cells. So, you know, it's the idea of precision, the idea of lack of collateral damage is a sort of a good analogy that I think that works here. So we're combining next generation robotic arms that are inexpensive, lightweight, highly precise, and small relative to conventional robots you'd see making cars and other manufacturing processes, and combining it with advanced imaging that can take a preoperative image, register it to a live video image at the time of surgery, and not only navigate and sense the position of a probe or a surgical tool, but give added information to the surgeon when they're looking at a live image that can come from really a CT scan, an MRI scan, an ultrasound scan, or other imaging tool that one can superimpose on the target. We also have developed microendoscopic tools. And this is the idea of being able to go places in the body that previously have not been able to reach and really retain capability to do much. So this is the idea of tiny cameras connected to robotic endoscopes that together can navigate through very tight spaces in the body and be able, upon arriving at the tissue target of interest, to be able to deliver therapy. Now, I'm sure everybody's heard of endoscopy. That's what they do today. They put a scope down your throat and look at anatomy. The problem with that is that it has very little control. It's rather large, and there's no real surgical capability associated with those devices. So it's taking the ability to to really add surgical technique to an endoscopic procedure. This is a cataract surgery, and it is being done by a fully automated technique. In other words, these instruments have been told to draw a perfect circle on the surface of the lens of the eye. And this is a technique that, yes, can be done by human intervention, but you spend many years in school and many years in residency and really don't get good at making a perfect circle, which is important, not to go sort of off-center in cataract surgery. You can take years to learn how to do this. The robot can do it perfectly every time, does not get tired, does not get distracted, and it's an example of how automation can be combined with robotic technique and guidance to the surgeon to add to the surgical capability. So the last part, which I think is also very powerful, that I'll mention in just a second, is this idea of data networking. What am I talking about here? I'm talking about using the data that is retained by robots, retained by video cameras, retained by sensors, and over thousands of procedures, understanding what the data tells you. A robot records every surgeon it makes or the surgeon asks it to make. It then can compile and store and look at historical information that combines a number of data points such that that data can drive better intervention. So we're already doing this today. It has sort of endless possibilities, but it isn't something that you have to wait 5 years to do. Our first clinical trials was in intervention in the kidney with our robotic endoscopes. And believe it or not, we use an Xbox controller to drive a digital robotic endoscope. And the surgeons love it. And the younger they are, the better they do. So this is a surgeon driving up the ureter in search of, think of the search and destroy mission, in search of a kidney stone that is too large to pass and is causing disease of the kidney. One is able to be out of the way of radiation, in fact, use radiation in an almost negligible manner because of the ability to control the endoscope and drive to the target, and then, as a drone might do, shoot a laser at the kidney stone until visually he or she can determine that the stone has been broken to small enough pieces such that it can be passed by tissue. Now, do they do this today? Yes, but do they do it with the ability to navigate, with the ability to control the tip, with the ability to target a stone and afford perfect stabilization at the point of the anatomy? They can't even get close. It is our first trial. It was a small trial. It was extraordinarily successful without complications. What's the value equation here? It's a number of things that we think are enormously important for both increased precision and a better outcome, but also driving costs down associated with these procedures because of speed, lack of complications, and ease of the procedure. So you don't have the enormous variation between somebody that's done 3,000 and knows perfectly well how to do a procedure manually, and somebody who's done 100 and may either take way too long, injure the patient, or have to resort to an alternative therapy. So access and speed, precision and control, out of the way of radiation, and avoidance of alternative therapy is the value equation to this procedure. We've also done it in lung intervention. This is another procedure that requires navigation. It requires control at the tip. It requires delivery of tiny cameras to see anatomy, to target tissue. And what's exciting about this is we believe it can usher in really a new era of the treatment of diseases of the lung, specifically lung cancer, that can afford the opportunity of avoiding lung surgery for cancer patients and doing what we call a bronchoscopic approach. So you see this clinician has navigated to a target that is clearly abnormal. The biopsy is taken, and this is being done hundreds of thousands of times a year in this country. They make a diagnosis, and here's the problem. 65% of the time, they find the tissue they're looking for. They know that it's there by CT, but 65% of the time, they're right. 35% of the time, the patient goes home without a diagnosis. That's unacceptable, and it's solvable. And this is a big opportunity because Medicare has just allowed the reimbursement of smokers over 40. So thousands of new bronchoscopies that need to be accomplished by making a solid diagnosis. First time out, in 150 lesions, we were successful 91% of the time, which is a dramatic improvement over all current technique and without complications. So very excited about where this leads in a number of specialties. Again, is it exactly the same value equation? Access and speed, stability and control, avoidance of complications. But we think it gets better than just a better technique, a faster technique, a cheaper technique. We think we can really change the fundamental nature of how surgeons better their technique and how we can move from everybody having a different level of skill to a system that shares information that can augment one's skill by robotic learning, by the computer learning as to what it's seen, what's worked, and what hasn't, and communicating that to the physician that's doing the procedure or the physicians that are interested in other people's experience. So, there's a surgeon windshield and a robot windshield, and they're different. The robot sees different things than the surgeon sees. It sees digital information, and we can use that information and the ability to see tissues at different wavelengths and record, soup to nuts, what happened in the procedure, to really integrate and learn from over time how to do a more effective technique. So I use the analogy of the smart car that's just getting smarter every day. So your car, you still drive it manually, but it can tell you where the center line is. It can tell you whether there's a pedestrian approaching, and you're getting a lot more information, making you a better driver, making it safer, and it's only going to get better. Automated driving is coming. Now, is automated surgery coming? In certain situations or certain parts of procedure, I think it is. But here's sort of the take-home. We believe that the role of the surgeon is changing. Technology is going to take a very important place at the table, and the surgeon's real value is going to be more on the side of great judgment and deciding what to do and when to do it, rather than necessarily being the great hands, the great technician that somehow magically does things that are very difficult to do from a dexterity standpoint. So we're moving quickly. We're excited to introduce a system next year. And this system will be able to provide therapy for lung, kidney, and GI applications. And in the next 3 following years, we're going to take over, we believe, about 85% of what's done in the operating room. In other words, this robotic platform will be versatile enough to be able to do most of what a surgeon wants to do. So the idea that we think doesn't work is to build a robot for a particular application. What we believe does work is to build a broad-based enough capability so the robot is there if the clinician chooses to use it, and can be out of the way if the surgeon doesn't use it, and it can use a level of capability appropriate for that individual procedure. And over time, we believe that the robotic system will be appreciated more and more by the clinician for not only technical reasons, what it can do that he or she can't do, but the information flow and the ability to really compile so much information about a particular procedure, approach, or surgery that the surgeon is invariably going to do a better job, a safer job, and have more success in their practice. So thank you very much.
Thank you. Outstanding. On behalf of the group that you referenced at the beginning of your talk, those that turn 65 every year, whoever they may be, we thank you for what you are doing. So it was interesting, in one of your last slides, you talked about automated driving, which is getting right back to your field, coming from Ford Motor and what you've done in that area. I was just wondering, with respect to what Fred was talking about in data mining and the information, not just what the robots can do from technique, but the information and how that's used. How do you use that with respect to the predictive analytics of your robots?
Obviously, we use the data for two things in the short term. One is to the obvious monitoring surveillance, but also to influence our autonomous technology stack. So you really don't want to have the one sensor that tells you everything in the world. What you really want is to mimic how a human digests data. You don't walk down a hallway just with one sense, right? You really want to ingest all events, start putting some probabilities on what is correct and what's not. But if you fast forward 10 years, what could you do with that data? A lot of the insurance companies have approached us and said, okay, well, we set insurance rates for property values annually. We don't have any other data to justify a dynamic insurance rate, but we actually would have the ability to establish a dynamic insurance rate. What about Google and Apple can get you home driving, walking, or what have you in terms of mapping? Would it be interesting to have the safest route home, right? We would have all the analytics and all the data, the historical data, and then you would be able to superimpose, lighting conditions, what license plates are there, what people are there, and all that interesting stuff to get you the safest route home. So there's a lot of interesting things you can do with the data. It is a lot. It's a lot of data, but I think probably the one takeaway I'd like to share with the group is the pace of change is much more dramatic than probably in your wildest dreams. The last 10 years, yeah, we've had a lot of change. The next 10 years are going to make the last 50 years combined pale in comparison. And if you're a hedge fund or a researcher or anything, I would strongly suggest you relook at your assumptions of what's going to happen over the next 10 years. It's going to be a lot more dramatic, and I'm not sure everyone's as well prepared as Hollywood might have set us up for.
Oh. Well, as we talk about the rate of change, Nina, and what you hear these gentlemen are doing, and with your background in electrical engineering, what do you see the applications for tissue reproduction, especially for the bone, of some of this data information and also the ability to do such precision surgery?
Well, I think there's a couple of intersections. From our perspective, one thing that we need to learn more about is how to implement things as simple as quality control. How do we map that towards a tissue production process in which your own cellular material is the starting point, right? So there's a lot of data that we're going to need to mine in terms of genetic profiling and correlating that with tissue quality and then coming up with analytics that we can then present to the FDA to show that, look, we've got prospective as well as post hoc analysis that show that we've got a good quality graft, likelihood for good quality graft. I think another area of intersection from my perspective is is just how much of a manual process a lot of what we do currently is. There's a lot of know-how to train tissue engineering, personnel, and that's actually, if you consider how fast the technology is moving and the rate of change, we kind of have a talent shortage on our hands. And on the other hand, do we really want manual processes to be dictating, all of that pipetting, right? That's all manual. So I watch with very eager eyes as automated cell culture systems are becoming more and more the norm. And I think this is where there's some overlap, because there's a lot of dexterity involved in the development of some of these systems, but we're wowed by some of the systems we're seeing coming out of Japan. And then finally, in terms of the actual surgical interventions themselves, I didn't see on the list which category some of the orthopedic procedures would go into. That was actually my question, and in terms of the arthroscopies, like how would we best implant a tissue-engineered ligament, right? With 2 bone plugs on each side. What would be the best way to? We see EpiBone as kind of a cell delivery mechanism. Everyone knows that location, right? It's one thing to inject stem cells into the heart, but the heart's a very good pump, and it's really good at getting rid of whatever you put in there, right? So how do you think about hydrogels and delivery mechanisms that keep those stem cells where they need to be? And I think that as we, in our field, develop more and more complex grafts that have a better chance of integrating very well, I think developing the concomitant technologies for how to get those implants put in with less and less invasive methods, I think is going to be very important as well.
So Fred, I'll throw it back to you, since Nina's asked the question, how are we going to use what you're doing in the orthopedic field and bone?
Yeah.
So I don't think I can answer that, other than we can do great arthroscopy.
Okay.
But I would say, what's I think exciting about the capability is that, when you show up your first day of medical school, one of the things you hear is it's extraordinarily important to get good at a physical exam, because all of medicine can be learned from one patient. Never quite understood what that really meant, but it is true that all the problems of healthcare in the world can be solved in one cell. And the more we develop the understanding of the cell in all its forms, and how you grow them, how you stop them from aging, how you make them express proteins in a way that fight disease, it's all there. And the sort of research that you're doing is going to lead down the path of greatness, and we are all going to be beneficiaries.
Very much. Well, let me ask you this, Fred. Bill was talking about, when I asked him about data, about the fact today when we go home we use Google. I understand Google's very interested in the robotic surgery area. Why don't you tell us a little bit about Johnson & Johnson and Google and what they're doing?
So it was one of my investors, when he read the news that Google was partnering with J&J to develop surgical robotics, he said, this is either the greatest thing that's ever happened to us or the worst. Because these are 2 monolithic companies that are teaming up. Now, it is surprising, but also I think logical in the sense that Google is all about information. Johnson & Johnson is all about surgical tools, and they turned their back on robotics for almost 2 decades, and they finally figured out it's not going away. We're going to have to get involved. And so they're just starting to understand what it means to build a robotic system, which is good for us. But the Google connection, I think, affords them a very interesting capability of partnering with a group that are masters of gathering and compiling information and figuring out what to do with it. And what I just described is we want our robot to do that same thing, to record, process, and over time understand what that information needs and how you can use it. So I think the Google J&J collaboration, it's an interesting clash of cultures. It's brand new, and I have my doubts as to how fast they can progress. But yeah, I do think on the surface of it, there is some logic there. And I'm glad that the recognition of how much information is lost on a daily basis in medical intervention, and how that information, if compiled, might be used. And it's going to be a great adventure, but I think it's very exciting.
Yeah. I think the whole idea of information and how we use it in the future and cross-disciplinary cooperation is a very, very exciting idea. Speaking of exciting ideas, tell us about the Tokyo Olympics and how that's going to affect your company.
Oh, okay. So one of our first investors was NTT Docomo, big telecom company in Japan, wireless. The Japanese Prime Minister has made robotics a kind of a strategic thrust for Japan. So we've been invited to evaluate the opportunity to do our global launch in the 2020 Tokyo Olympics for Nightscope. So we're focused on the US, and until then we've got our hands full, but it's going to be an awesome opportunity.
So we're going to have a whole robotic team at the Olympics besides our track team, our swimming team. I think that's fantastic as we go ahead and we move into that area. One of the things we talk about in cross-disciplinary, you and I have talked about other people we've had on our panel that have been involved in tissue reconstruction. And at the Prostate Cancer Foundation, we have found that a lot of our successes are by collaboration and making sure that the doctors and scientists all collaborate. And I know you work with others in this field. Tell us a little about the collaboration that goes on in your field.
Oh, goodness. There's a ton of collaboration. I mean, I think first and foremost for us, we have a co-founder of our company who's a surgeon. I think we wanted to make sure that we had the surgical perspective even on day one. And we're highly collaborative with, the New York City ecosystem's pretty good for us to make friends with our neighbors. And one thing that's interesting for us as we think ahead is which are the right kinds of strategic partners that we'd like to cultivate. And the way that we think about this is who are we going to likely be the future customers of? How are we? What kind of bioassays are we going to need going forward if there's clinical trials need to support living devices, right? How do things like dose and half-life map when your therapy is alive? And so for us, cultivating relationships in bioassays and molecular imaging and diagnostic space is very important. We also have collaborative projects in the 3D printing space as we think about materials that are getting better and better, biomaterials at being printed. Right now, there is no material that's as good as decellularized bone as a starting material for growing bone, but that's changing, and the biomaterials field is so rapidly advancing. And so again, for us, we think, well, we'd love to be customers down the line, big customers of these next generation 3D fabrication devices. And then finally, as clinical trials are changing, as we think about what are the endpoints we need to measure, and as things like the Apple Watch and Fitbits become more and more accepted as part of the regulatory environment, I've got one. Thanks to my boyfriend who stayed up till 3 a.m. to get it. But anyhow, we think about, what are some interesting things happening in the clinical trial space as you think about, more and more less invasive endpoints of, user-generated data, and what does that mean for devices like ours where quality of life measurements are likely going to be very important. And so we've been highly, highly collaborative in those three spaces. I can't name names. But they're household names. And so for a small startup of a team of only 6 people, collaboration is a way for us to amplify our efforts. So absolutely, without collaboration, we have nothing.
Well, it's very interesting because what you're really saying is in this whole tissue regeneration issue, it's not just developing human tissue for implant, but by developing real human tissue in the lab, it will speed up both in time and in quality the testing of drugs.
Oh yeah, we see that that's the secondary effect. I mean, we hope to disrupt the world of healthcare in those two main ways. We are first of all and foremost, developing personalized medicine products, right? These are how more personalized can you get than your own cells, right? And on the other hand, we do see ourselves as facilitating through development of kind of next generation bioassays an ability to test how drugs are going to work in people before putting them in people, right? And even if you just think, I mean, my research was all on cardiac tissue for my PhD. For those of you in the clinical trial space, you probably know that idiosyncratic cardiac events, a polite way of saying we don't know what happened, is a very common reason for late-stage drug withdrawals. Very costly in terms of money and, of course, in terms of human impact. And if we could test how a drug would work in a human heart by growing an organoid, a small cardiac piece of tissue in the lab, we can speed up that feedback loop between asking a biological question and getting a biological answer. And in terms of bone, a lot of people ask us about osteoporosis or ask us about even things like bone density for astronauts, a wide range of things people like to ask us about. But one thing I do think worth noting is that if you think about two of the most highly prescribed classes of drugs, statins and antidepressants, both of those have unintended bone side effects. And as the population ages, these kinds of diseases are going to be so much more important to keep on our radar, and we're going to want to know before we put a drug into a person, how that's going to affect their bones. So we do see ourselves as kind of having this dual mission of kind of disrupting the clinical trial world, but also in terms of generating therapies with a market size of N=1. Yeah.
Great. So we only have a couple minutes. I'm going to ask each of our panelists to just give us something they want to leave us with respect to what they're doing, how it might affect their lives, or something they want to leave us to think about. Whether it's the possibility of actually surgery being done over long distances from what you're doing or anything else. So I'll start with you, Fred.
Okay, well, so I'll maybe instead give you a story about the early efforts in robotics where, the Department of Defense developed robotics for surgery for long-distance applications. And we had a whole team of experts from NASA that were talking about astronauts and how we were going to operate on astronauts in the space shuttle. And wouldn't that be a great thing?
Yeah.
And it was a big convention. Everybody's very excited about it. And so one guy raises his hand and says, well, isn't there a time delay when you move, at the workstation by the time it gets to the patient? Isn't it going to be the time lag going to be a real problem in actually accomplishing the procedure safely? And the answer was, well, no, because there's the patient's asleep. It's not going to move. They're not going to move, and so it'll all just be a few seconds after you move, it will move. And another guy raises his hand and says, well, doesn't the space station rotate as well as, so, and is that going to be a problem with the time delay? And the guy goes, God, never thought of that.
Okay, I think that's the things we haven't thought of there, basically.
Right.
So, Bill?
Given the clock, we'll do this Silicon Valley style. While we're sitting here thinking, it's like, okay, what could we do 10 years from now that blow your mind?
Right.
Just thinking, well, the K5 that you saw is probably the smallest machine we'll build. There's a K7 and K10 for rougher terrain and much larger, 15 and 20, but we could probably do a K20 autonomous ambulance with a 3D printer and some milling capability, and have
Yes.
deliver the robot and your robot, right, or
Right.
your materials and your robot, and do autonomous work for the hospitals in 10 years.
So,
And I can't resist maybe asking a provocative question. What happens when we start to think of cells as living building blocks, and I think about my niece Sonia, who loves to play with Legos. And, I think about the world that we're going to be creating for them, but maybe more importantly, the world that they're going to create for us, these kids who are toddlers now. And, if the first industrial revolution was about machines, right? And the second one that you could argue we're in the middle of right now is about information. As biology becomes more and more of a technological partner and is bleeding out of biotechnology into fields as diverse as architecture, art, and food, why not ask, if the first one was about machines and the second one about information, isn't it exciting to think that the third industrial revolution really could be about life?
I think on that note, we will end this with the understanding that whether or not we blew your mind, we hope that you understand that we are very lucky, we're very blessed in this country to have talent such as on this stage that is thinking about these things and thinking about them in a positive way of how we make the world better and how we make all of our lives better. I hope you've enjoyed it today, and it's been our pleasure to share some of these ideas with you. Thank you very much.